Hello, everyone. I'm Dr. Angela Mattke, and you're watching Ask the Mayo Mom on Mayo Clinic's Facebook Live. I'm a pediatrician at Mayo Clinic Children's Center in Rochester, Minnesota, and host of this show about pediatric health topics where we take and answer your questions live. Because of COVID-19 and the safety measures we must all take to be safe, we're coming to you live today via Zoom to maintain social distancing. Today, we are talking about type 1 diabetes. Joining us for this discussion is Dr. Anna Creo, a pediatric endocrinologist and expert in the management and care of children with type 1 diabetes. Dr. Creo is also the pediatric diabetes clinic director at Mayo Clinic Children's Center. Our second guest is Janet Hansen, an RN care coordinator and certified diabetes educator at Mayo Clinic Children's Center, who works with families to help optimize their child's diabetes care. Please send in your questions about today's topic, and we will try our best to review them during the live broadcast today. However, we cannot offer specific medical advice for your individual family's circumstances. Dr. Creo and Janet, thank you so much for joining us today.
Thanks for having us.
Thanks for having us.
This is such an important topic, and it affects so many children and families in the United States and throughout the world.
Absolutely. And the numbers are just growing in both type 1 and type 2 diabetes.
Absolutely. So, what is type 1 diabetes and how is it different from type 2 diabetes? You mentioned both of them.
Yeah, it's a great question. This is probably the number one question we get from families. And it really is confusing because while diabetes is common and both types are common, there's far more people in the world with type 2 compared to type 1, but they're treated very differently sometimes depending upon. So, to kind of in a nutshell, we'll start with type 2 diabetes. That's what most people are common with. That's the kind that's associated with kind of lifestyle habits, excess weight gain, poor exercise. And really, what's happening with type 2 diabetes is that the body is making insulin. Insulin's a hormone that our pancreas makes. It's kind of like the lock and key. So when we eat food, it releases and helps kind of the sugar to go into our muscles and body where we need it. In type 2 diabetes, the body's making insulin, but it's just not working as well. It's resistant because of the extra weight, typically for most people. So, the treatment with type 2 diabetes is really focusing on improving lifestyle habits. Sometimes people need a little bit of extra insulin, even with type 2 diabetes, but for that type can really be oftentimes managed with improving the lifestyle. Kids can get type 2 diabetes, but as common is type 1. And the difference there is that that same pancreas that makes insulin, the problem is that it's in what we call an autoimmune condition. So it's cells in the body that get confused, and instead of fighting off a cough or a cold, they start to attack the pancreas and slowly cause enough inflammation that the pancreas can no longer make insulin. So, unlike type 2, where the problem is there's just plenty of insulin, but it's just not enough, type 1, the problem is that there's been an autoimmune attack and the body just cannot make insulin. And that type does not have a relationship to being overweight or not exercising or eating too much candy or things like that.
So, do we know what causes type 1? Because it seems like it just kind of all of a sudden happens, as kind of how you were describing it.
Yeah, absolutely. So there are some standard antibodies that we can check that most people with type 1 diabetes have. And what's kind of, as we're learning more and more about these, the cells that get confused or the autoimmune process starts over a year, sometimes up to 2 years before we actually detect full diabetes. So these cells are annoying the pancreas, they're causing inflammation, they're destroying cells that make insulin. The cells that make insulin are called beta cells, kind of like a beta fish, beta cells. And they are going ahead and they're just destroying these insulin making cells. And you actually can lose about 95% of these cells before a child actually develops diabetes. So by the time we see a child with new onset type 1 diabetes, most likely this process has been going on for at least a year.
Hmm. Wow, that's really interesting. So, if type 1 diabetes is an autoimmune disorder, are there other disorders that can kind of happen at the same time or happen later if that immune
Yeah,
system's kind of not functioning like it should?
absolutely. There's kind of families of what we call genetic risks that kind of have a cluster of tendency towards autoimmune conditions. If you're a sibling of a type 1 diabetic, that increases your risk already because you tend to share some of the same genes. And as we're learning more and more, we really understand there's certain genes that are really linked towards a much higher risk of developing type 1 diabetes. But the other common conditions that can travel with it are autoimmune thyroid disease, where this different antibodies, but the same tendency are attacking the thyroid gland, or celiac disease, which is a problem with kind of wheat and wheat tolerance. And so those are the three that most commonly travel in a cluster together. And while there are many, many, many kids that have either thyroid disease or celiac that never develop type 1 diabetes, it does increase your risk just a little bit if you have one or those conditions of type 1 diabetes. What we commonly see is if in a family there may not be type 1 diabetics, but there's probably a history of maybe mom had thyroid disease, there's an aunt with celiac disease. They kind of travel in clusters and families.
Okay, so you
And there
mentioned
are
that.
and there are
Oh,
families too where,
yeah.
gosh, every sibling in the family eventually got type 1 diabetes too. So we do have families where there's more than one kid that develop, and we think those families probably have a special genetic tendency to
Okay.
really have more diabetes.
And they have been able to identify some of those genes, and if they do carry that gene, does that mean that they're automatically going to develop type 1 diabetes, or is it
Yeah,
other steps need to happen first?
it all depends upon kind of what gene, and it's kind of what we call a two-step model where you have the tendency and then there's probably some secondary hit. Maybe you did get a cough and cold and some of the cells got loose and got confused, or there were other stressors as well. As we're learning more and more about now, kind of some of the leading edge is trying to identify those kids, whether it be by genetic testing or by just checking the antibodies well before they develop diabetes and see if it can be prevented. So we can talk more about that later, but there's a lot of exciting updates.
Yeah, that is really exciting. So, before we kind of get into the symptoms of what to look for, I have another question kind of about other genetic disorders that might run with it. Cystic kids with cystic fibrosis, can they develop diabetes? And if so, which type is it? This isn't a great audience question about someone who does have a child with cystic fibrosis.
Yeah, so in addition to type 1 and type 2, there are other less common types of diabetes. So cystic fibrosis is one. In that condition, just because of all the pancreas, you get cystic fibrosis related diabetes. So
Hmm.
it's it's really its own type where it's a combination of the insulin sometimes doesn't work as well, but you actually just lose some of the insulin secreting ability too. So absolutely, we know that recognizing, we start to recommend by age 10 screening kids for CF or CF related diabetes. There are other even rarer types where babies can be born with neonatal diabetes. And there's something called monogenic diabetes, which is a super rare type, but again, is another thing that is independent of an autoimmune that just runs in families where they have a change in how they metabolize glucose. So all three of those are much less common, but again, very important.
Okay, great. So let's move on to talking about recognizing those symptoms. Dr. Creo mentioned that it can take a year or 2 years as that autoimmune process is kind of revving up before you might start see some of those symptoms. So, what would parents be looking for if for changes that could be happening in their child that would signal that type 1 diabetes is developing?
Yeah, it's very interesting during that time period while the autoimmune system is doing its thing. Most often there's really nothing to see. Families don't know that this process is happening. The body is able to accommodate and still manage the glucose fairly well. But it's at that point that Dr. Creo mentioned when you've got at least 90%, 95% of those beta cells in the pancreas destroyed, that's when the symptoms start to occur. Most commonly, what you're going to see is excessive thirst, excessive urination. It's not uncommon for this to be found sometimes on a road trip of, you know, one of the kids saying, okay, when can we stop? I need to go to the bathroom. What do you mean? We just stopped 20 minutes ago. It's pretty amazing how thirsty they can be, or, you know, little people, a 5-year-old just drinking 16 ounces of water in a matter of minutes and then looking for more. So it is very extreme with seeing that. Some of the other things that you can maybe start noticing is some weight loss, some fatigue, decreased energy level. Sometimes it comes about, they've had a cold and it's like this cold just never goes away. They just can't recover from the cold like they typically would.
Mhm. Yeah, absolutely. And so, because it's kind of so like sinister and like very slow kind of symptoms that kind of build up, does it all of a sudden hit like go and it just happens really quickly once that insulin production just isn't there anymore, or is it kind of a really slow gradual process?
Once those symptoms start, it can go pretty rapidly
Okay.
at that point. And one of the things I do chat with some families about, and parents especially, when they hear that this is a process that's been going on for about a year or so, there's often a lot of that parental guilt
Hmm.
of, what did I miss? I should have caught this, but yet maybe those symptoms have only been there for a week or two,
Hmm.
that it's fairly short. And so sometimes it can go very rapidly, and especially if they're not looking for those symptoms, or older kids who don't need to ask their parent to go to the bathroom for help, or they just go to the refrigerator and grab a drink. So sometimes on those independent kiddos, it's really hard for parents to even know it's been happening.
Okay. Sometimes when children present, they have really, really high and very kind of scary glucose levels that can have a lot of other complications, and that's something called DKA. Can you tell us a little bit more about that, Dr. Creo?
Yeah, DKA stands for diabetic ketoacidosis. And what that is that if someone has type 1 and even type 2 diabetes, if it's really poorly controlled, if there's just not enough insulin there, as the body's trying to metabolize glucose, but it can't, the body's kicking out extra acid. And that acid is called ketones, but it can really make children have the acid in their blood be built up and can make them really ill pretty quickly. About 30 to 40% of all kids with type 1 diabetes, the first time we decide or discover they have diabetes is when they're already in this DKA. And even there's some new studies with COVID, it's even more so because everyone's trying to be mindful, social
Mhm.
distance. They're not necessarily at school where their school nurse or teacher would notice weight loss. And so we are seeing even more DKA this past year. And it's treatable, but it can be life threatening if it's not recognized. Sometimes families that are known to be diabetic, if they're missing insulin as well, they can go back into DKA, but we talk to our families. It is a preventable thing when you know what to look for.
Okay. As children present to maybe, their primary care provider or urgent care or some type of emergency department with these symptoms, what does that initial evaluation look like? Does it automatically mean hospitalization? What should families expect?
Yeah, so the most important thing is that it's never normal for a child to have an abnormal blood sugar. And that's one of the most things just emphasizing for any family is that unlike adults where sometimes they can have a slightly high blood sugar here, blood sugar there, any child who's had an abnormal blood sugar at least needs follow-up. If the tests come back that are suggestive of diabetes, what we really do, and kind of get into that, there's different ways we can diagnose diabetes. The two most common ways is either what the blood sugar is. So we check kind of blood sugar lots of either by a blood draw or point of care. And if it's high enough, that can diagnose diabetes. The other way is something called a hemoglobin A1C. So someone very smart figured out that red blood cells in our body last 90 days and sugar attaches to red blood cells. So it's very easy actually. We just spin down a child's red blood cell. We look at how much sugar is on the red blood cell and we can estimate with really good accuracy what that average blood sugar has been for 90 days. So that's another very common way to diagnose diabetes. So if the hemoglobin A1C is abnormally high, then that's another diagnosis of diabetes. As far as then for the management, it really depends upon if the child does have acid in the blood, then that has to be to the hospital for sure in any institution. If the child doesn't, it depends upon a lot of factors: where they live, their family's comfort. Is this the third child with type 1 diabetes in the family? And so we kind of make that we take a very individualized approach for every family.
Okay. Um, what about the treatments? I mean, I would imagine that this involves insulin in some way, shape, or form. But Janet, can you talk a little bit more about what the treatment process would look like? What kind of education that families are going to get to help them with this process?
Yeah, there are a lot of, skills-based types of things that we do need. the kids, the parents, depending on the child's age, to learn. One of those is how to test their blood glucose. Just needing to know how to test it, when to test it, what do those numbers mean? If what is considered a low, a number that is too low. How do I handle that if it gets too low? Dr. Creo was talking about that acid, those ketones in the blood. So we need to make sure that families also know how to test for ketones in the blood or the urine. So we talk about what number is too high. When should I be testing for those ketones? And then looking at insulin, just like you talked about, most often kids are going to start with injections. Probably the most common treatment program would be something called a multiple daily injection program. It's a combination of fast-acting insulin and long-acting. And so with insulin, we're always trying to mimic a pancreas. So what would my pancreas be doing? A provider I worked with when I first started in this job always talked about, we're going to put on our pancreas suit and pretend to be a pancreas. So we look at that insulin, and we're giving fast-acting insulin with meal times, because that's when a pancreas would be creating and excreting a larger amount of insulin to kind of handle the carbohydrates that break down into sugar in that food. And then there's also going to be an injection of a long-acting insulin, which is going to be just a little bit of insulin that's being released all the time, which is also another job of our pancreas, that we have insulin around even when we're sleeping, and so we need to kind of have both of those. So most often we're talking 4 injections a day to start with for these kids, and that in itself can be a little bit to adapt to over time.
So one question that just kind of popped into my mind that I imagine that you hear from families is why do we have to do injections? Why can't we do it orally?
Yeah, this is a question we get every, grandma
Hmm.
treats her diabetes with pills. How come
Right.
I can't? And the pills, what they really do is they just stimulate either the insulin in the body to work better, or the pancreas just to squirt out more insulin. But in type 1, there is not pancreas beta cells left to squirt out any insulin. And the insulin's working fine. It's just a matter of getting enough. So in type 1, unfortunately there's no pill. And they've tried to give insulin in so many other ways, in the nose, in the mouth, and it's just not stable right now. So unfortunately, injection is our only option. And again, just like what Jan said, that's one of the hardest parts for young families with younger children. It's not uncommon to have a 2 or 3-year-old type 1 diabetic, and getting used to the daily injections is a big adjustment. It fortunately is a very fine needle. It's right under the skin. And after, Janet, what do you think? 2 to 4 weeks, it kind of becomes part of the routine. But the first couple weeks are pretty difficult for families.
Yeah, I definitely think so. And I didn't add in the other thing that we really have to talk about is food. How to look at foods. Families need to know that, what has carbohydrate in those foods. What's going to break down to sugar, and that also helps then to decide how much insulin they need. And similar to Dr. Creo talked about those pills that work for somebody with type 2 diabetes, sometimes the thought is, well, if I just don't eat any sugar, then my diabetes is taken care of. But when we're talking about growing kids, we need to make sure they're getting those calories, and it needs to come from all sources of food. So that's another thing that we do have to talk about. And thankfully, we've got dietitians that we work with that help us with that too.
Yeah, it's a great point. Many well-meaning friends and family just say, well, gosh, if they just eat a little bit better or cut out the soda or go on a keto diet, can we fix it? And the reality is we can't. You need insulin, whether it's fat, protein, or carbs. You need the most with carbs, but you really need all. And many type 1 children have lost a lot of weight. If anything, need more calories and more carbs to feel better again. So while it's well intended, it's definitely a different treatment.
And another challenge, you mentioned on it, but I just want to kind of talk a little bit more about it is checking glucoses. I mean, it's not just once a day; it's multiple times per day. And how do you help families with that challenge, especially in those first 2 to 4 weeks, as kids are getting used to being poked and prodded and having these painful things happen with them?
Yeah, I mean, we want every family needs to know the basics about how to. We work with child life and psychology to get the finger pokes down. But we are fortunate that there's never a great time to have type 1 diabetes, but
Hmm.
if there is, it's now compared to 15, 10 years ago because there's so much new technology to
Yeah.
really help out. Nothing can cure diabetes, nothing can take away those fundamental skills, but there's a lot of things that can really either kind of improve the lifestyle or control. So the first one is something called CGM. What that stands for is continuous glucose monitors. There's a lot of different companies and different brands out there now, but I brought some in. This is just about the size, if you can see, of a CGM. All right. And it would sit, on an arm, on a tummy, on a leg. And depending upon the brand, it can last up to kind of 10 days on a child. And in real time, it's always sensing what the blood sugar is. The way it really works is that there's a little I talked about it, it's kind of like a piece of astroturf. It's soft, it's flexible, no needle stays in the child, but it has all these electrodes and it's sensing what the blood sugar is around the cells in the body. And it uses algorithms to then determine what the actual blood sugar is. So for a lot of families, these are great because it does reduce the number of finger pokes. They still sometimes have to be calibrated. So if the sensor thinks it's a little bit off, you
Hmm.
do have to do a finger poke to affirm. Or if you're having a low blood sugar, you still have to do a finger poke to be sure. But it definitely reduces the number. And then it really is helpful too in that it can look, there's many of these are connected to different software on these phones or computers where multiple family members can know at one time what that child or teenager's blood sugar is, or if the teenager is with friends going to be driving, rather than having to get out all this equipment and kind of trying to keep things discreet, just looking at the phone, you can tell what the blood sugar is before, say, they get behind the wheel. Sometimes our teens do get a little bit annoyed that mom, my blood sugar, I've treated it, I have it under
Leave me alone.
control, let's back off. So we do recommend having a good system of communication, even in emoji, thumbs up, mom, dad, I got it, I treated my low, don't worry about it, I saw that. Or no response, then parents have permission to keep pounding. And so there's a lot of pros that come with these glucose sensing technologies. Even in adults, and there's something that goes in the arm, kind of like other contraceptives, and it stays in there for 90 days. So it's really getting exciting how small and how high tech these are. And some of them too then are talking to other technology like glucose pumps.
Yeah.
Awesome.
And I think, the one thing to add, especially for new families, continuous glucose monitors are fantastic. Would love everybody to have them, but it can also be overwhelming because it's giving you a reading every 5 minutes. So sometimes seeing this and we have to talk to families about, okay, just put your phone down and don't look again because they're looking so actively, and
Hmm.
sometimes until they get used to finding that
Hmm.
balance, they may drive themselves crazy as
Right.
well. So
Yeah. Too much
yeah,
information. It can be an overload for them, I would imagine.
right.
Hmm.
Yeah. And even too, a very well-controlled type 1, when they're doing finger pokes, they may say, oh, I'm in range before breakfast. I'm in range before lunch. I'm in range before dinner. But when we turn on these glucose monitors, they say, oh my gosh, I went up to 200 and then I went down and then I went up
Hmm.
to 200. And so to educate, it doesn't take away diabetes and you will see more data than you're used to. So I very much agree with Jen on that point too.
Hmm. Absolutely. Okay, you mentioned glucose pumps or insulin pumps, excuse me.
Yep.
Can you please tell us more about those?
Yeah, so that's the other kind of exciting, and that we've had insulin pumps for a while. And what those are is, again, it's probably depending upon the pump, either like 2 or 3 or 4 of these kind of all put together, depending upon which brand. Some have tubing and others don't, but they sit on the body and they're always delivering a little bit of insulin. So the way they work is that there's what we call a basal rate. So it's always delivering a low level. You can set it hour by hour for most brands, varying if it's sports practice, sleep, time of day. And then when it's time to eat, you bolus the insulin. So you put in what your blood sugar is and how many carbs you're having, and it'll give you that squirt of insulin, like Jan said, just to mimic to try to be a pancreas again. So that was kind of the first generation of pumps. It does not take away diabetes and it does not make things easier. If anything, sometimes pumps add a little bit of complexity, but it does kind of add some fine tuning, calibration, and flexibility. But what's cool now is there are newer generations of pumps that talk to sensors, or the CGMs. So at the very beginnings, there was something where the pump and the sensor were always talking, and if the pump predicted the sensor, or sorry, if the sensor was predicting a low blood sugar was coming, it would turn the pump off. So you would turn off the insulin so you wouldn't have as bad of a low blood sugar. What's happening now, though, is there's something you've probably heard of, closed loops pumps. So depending upon the brand, then the pump and the CGM, or the sensor, are always talking, and the pump is slightly adjusting whether it's the basal rates or the boluses based upon what it's seeing the blood sugar. And it has that same technology of predicting and avoiding as much lows. Also, too, if someone's going high, then it kind of squirts in a little bit extra. And what's really fun now is there's another generation of, so those are closed loops, advanced closed loops, where the pump is noticing that, oof, Jimmy's a teenager and Jimmy did not put in his bolus or his carbs for breakfast, but I see the blood sugar is going up. It will kick in and still give, up to the 60% of that bolus as well. And the next generation, even they're talking about, you may not even have to put in the carbs anymore. It may just predict, oh, Jimmy ate eggs. I know eggs. Oh, nope, this is cereal. I know cereal. And it will really match the insulin delivery to the glucose rise. So it's really exciting. Again, right now, they still add a lot of work and a lot of technology. And for some families, it's too much. I had a teenager recently. It was almost like it was a mom of a colicky baby. My pump keeps yelling at me. I can't take it anymore, because they do need a lot of data. So it has to be the right fit for the right family. But it is exciting.
What about, there's other, ongoing, I mean, obviously ongoing research all the time into this, artificial pancreas transplants, some type of pumps that do other things other than insulin as well. Can you talk a little bit about those?
Yep. So starting with that, pancreas transplants, we'll start there. We're trying to, have methods to either transplant a whole pancreas or put beta cells back in. But there still is the overall problem of keeping the beta cells healthy, because that same autoimmune attack is going in. Sometimes right now it takes more immune suppression with more side effects than just the diabetes and insulin. So while there's progress, we're working on that, and it's still a ways off. As far as the two hormones, what we call those are dual closed loops. So we always talk about insulin, but the secret is there's another cell called alpha cells that make glucagon, and that's another hormone that helps just stabilize the blood sugar, especially with low blood sugars. And that there's some new technology looking at having both loops. There's a lot of challenges still in that glucagon is not as stable at room temperature, and it can irritate the skin. So there's a lot, and it's just a lot for a child to wear. Two sensors, one for glucagon, one for insulin, two pumps. It's just a lot, but it's really coming along, and I think it'll come with time.
Yeah, absolutely. Well, let's move on to talking about some of the challenges that both these children, these teens, and the families face, because their day-to-day lives are disrupted in the way that they don't get to be carefree with their food, and when they eat and how much they eat and stuff. So let's talk about how you prepare them, you help them through these challenges.
Yeah, and you're right. Depending on the age of the child, those things all happen at all ages with that. And thankfully, the technology that Dr. Creo just talked about really helps these kids get closer to that life pre-diabetes of, having your snacks when you want them, how big, whatever size, and that type of thing. So when, talking about technology is certainly a part of that. I think just trying to, some of it in the beginning is just conversations. Right now with families, we're talking a lot about the holidays, because we know we eat differently over a holiday than we do just on a regular day. And so really trying to come up with plans for those occasions. And, well, what are we going to do? We know you're going to eat more than you typically would at this time of day. Sometimes it's just trying to encourage families to talk to their relatives with, do we really have to have the Christmas meal at 3 p.m.? Could we have it at noon? To get it to more of a schedule. But we come up with plans for, what are we going to do for this? And sometimes it's just, okay, if you eat a little more, you're right, your glucose will be a little higher the next time you test. But if that's the case, at that time, you'll end up taking just a little more insulin. So, food issues can come about sometimes for young kids once they go to school. and they notice that their classmates are eating food differently than they would, or needing to come up with a plan. How are we going to manage school lunch? How are the lunch ladies going to know that he only gets half of the fruit instead of all of it, depending on the portion? um, there's lots of transitions, whether it's from being at home to going to daycare, and now we've got another caregiver involved, going to school, trying to transition teens into more independence, and then from there even ready to launch to college. So helping just parents figure out how to navigate that, and where do I back off, where do I step in, how do we work together to
Mhm.
make these things happen. Holding kids accountable to being safe when they're driving. That, Dr. Creo referenced it. We can't just not know what your glucose is if you're going to be behind the wheel of a car. Um, we have lots of concerns about burnout, for teens too.
Mhm.
Sometimes with all of this technology, there is so much information, and after a time you're just done with it. I don't need anything beeping at me anymore. I don't want something attached to my skin anymore. So it's trying to find that balance. And do we take a technology break for a little while? Some of the summer camps do that because they're going to be in the water so much and things like that. Some of the folks that are running diabetes camps recommend just taking your technology off, and having that technology break when they're there. um, just stress, whether it's kids not knowing somebody else who has diabetes,
Mhm.
or parents not knowing other parents. Sometimes when they're first diagnosed, gosh, I'd really like to know somebody who had a child who was 18 months old, and how did they do it? What were their tips? What did they learn? Sometimes they want to know somebody who's going through the same experience right now. Sometimes it's, you've been down that road, help me out. Um, and just trying to figure out, even for kids when they get stressed for an exam, a test, what, this is what my glucose does, what can I do with it, how do I get my glucose where I want it to be so I feel like I'm performing the best as an athlete. So I think all of those things are happening that these families are really trying to navigate, and hopefully we're able to come up with good plans. And as long as they're willing to continue to fine tune those plans, we frequently can get to a place that we want them to be at, or they want to be at.
Yeah, that's really helpful. You mentioned diabetes camps. How do families connect with other resources, or other people, support groups, national organizations, camps, other ways to help them adapt, help normalize their child's or their teen or their young adult's life?
Yeah, there are so many different groups. A common one is called JDRF. It's a nationwide group, but there's tons of different online websites and local regional chapters. So I that's another kind of great thing about being a diabetes doctor, just how robust these
Mhm.
communities are and how engaged they are.
Yeah.
Yeah, and there are some nice resources that are out there for college students. And it's how do college students on campuses connect together? In Minnesota, I believe it's Pacer helps with school issues. Trying to reach those 504 plans. There are some great websites as well. Children with Diabetes is a good website. Dr. Creo mentioned the JDRF. There's another, I think the group is called Beyond Type 1,
Yeah.
that's also pretty good. So we're thankful we've got a social worker on our team, so she really helps out with lots of those resources and tries to connect families too.
Absolutely. Well, thank you so much. We are reaching near the end of our time. Do you have any other things you want to add for families and patients?
No, just that having a good team, taking really good, and just knowing that things don't have to be perfect to be well controlled.
Yeah, definitely.
Absolutely. I feel like there's no such thing as perfect, right?
Yep.
It's your effort and what you put into it and how you kind of come together as a family to work through this. So, thank you so much for the time that you gave us and all of the incredible knowledge you shared. Thank you everyone who sent in questions. If we didn't have time to get to your question during the live broadcast, we'll be trying to answer it after. You can catch the next Ask the Mayo Mom Facebook Live, which will be on January 7th in 2021, and we'll be discussing the COVID situation and update about what we know about it in children, as well as the vaccine rollout. And we'll be discussing it with two pediatric infectious disease doctors, Dr. Puni Rajapakse and Dr. Emily Levy. So please join us if you can. Remember, everyone, stay safe. Remember to socially distance, wear your mask, and be kind to each other. Have a great day.
Thanks for having us.
Thank you.
Thanks for joining.